Good morning all to the second Grand Round lectures sponsored by the Shanks Foundation and the Pathological Society. I'm Professor Sarah Coupland. I'm president of PathSoc, and it gives me great pleasure this morning to introduce the Iris Nagtegaal, who is a professor of gastrointestinal pathology at Radboud University in the Netherlands, and she's been there since she's been professor there since 2013. She studied both medicine and biomedical sciences at the University of Leiden in the Netherlands, and she graduated in these studies in 1998 and 1996. She also did her PhD at the same university and graduated with honours in 2002. And the title of her PhD was Pathological Aspects of Rectal Carcinoma. So Iris has continued to concentrate on gastrointestinal pathology, and she's been very much involved in a large range of studies, international studies, and also textbooks, including the WHO classification of tumours of the digestive system, both the 5th and the 6th editions. It gives me great pleasure to hand the microphone over to Iris, and she will be taking us through her lecture this morning, which will be all about gastrointestinal tumours. Please take the stage, Iris. And for those who don't know, there is a Q&A box where you can ask questions, and at the end of Iris's lecture, we will go through them, hopefully covering most of them by 10 o'clock. Thank you very much.
Thank you, Sarah. I hope everybody can see my screen. It's a great honor to give this lecture, and it's also a great pleasure because the tumor deposit story is actually my favorite story. It has a plot, it has everything that the story needs. The plot is strong, the setting is great, there's the fight against the institution, there's conflict, there's a financial angle, of course, but it's actually a story about tumor progression, which is, of course, one of the holy grails in cancer research. But it is also my story, which started when I was a slightly naive trainee, and it's not ended now, but now I'm standing here for you doing these grand rounds. It also has a lot of things I think you would like morphology, immunohistochemistry, molecular biology, but also spatial transcriptomics, as well as artificial intelligence. But most importantly, I think it has the opportunity to improve patient care. So if I put this introduction in Copilot and asked it to draw a picture, then you have the background of my presentation, which is actually quite nice. So the story started when I was just a trainee, as I mentioned before, and it started with this sentence. The letter note was based on unpublished data which were not subsequently substantiated, which is a tongue breaker for a non-native speaker, but it's also kind of confusing when it is about TNM, which is actually one of the great rules in pathology and oncology. So I was actually very surprised. And when I read the next sentence in that article, which was stated on the contrary, several reports indicated the possibility that such nodules, which are associated with colorectal tumors, represent vascular invasion, and that this feature has independent adverse prognostic weight. And I was thinking, how do they do that? What? So very surprising. So what was my next step? I thought, well, maybe I have to look back in time. And of course, I must admit, I like the work of Clifford Dukes. And if you look through it, you will find, well, not always solutions, but at least hints towards also the common problems we have in colorectal cancer. And indeed, in 1935, it was already described by Clifford Dukes that tumor deposits exist, that they were definitely not lymph nodes, but they might have been the result of vascular spread. Moving on, nothing happened for 50 years until Bill Heald came along, and he actually thought that tumor deposits, like in this case 6 of his paper, were the cause of local recurrence. 25 years later, I came upon this sentence. And the interesting thing about TNM5 is that it was coined in 1997. And if you look at the references for these sentences, you see that these references were actually from before. So it kind of ignores the literature which was already there for TNM5 and just changed it in TNM6 based on these older papers. And what they did from TNM5 to TNM6 is that in TNM5, this unsubstantiated definition was based on the 3 millimeter rule. And then in TNM6, they came up with the smooth contour. And if you look carefully at the literature they refer to, it's not really there. Because this was the paper from Goldstein from 2000. And they actually said, well, there is no size criterion because as long as you can palpate them, they are there, which seems reasonable, but not really exactly evidence. And they considered rounded tumor nodules, not tumor deposits. And that's okay if they want to do it. But again, that's not really evidence. So the change in TNM5 to TNM6 was not really based on any evidence, but just an opinion. Well, what we did was a systematic review, which was very critical. We looked at the literature which was available up until that time, and we saw that the presence of tumor deposits was actually associated with a poor outcome. We also make some critical comments about the contour rule because we thought, well, if you think that a tumor deposit is an overgrown lymph nodes, then it's not very likely that the smooth contour will be retained, because if you overgrow your lymph node, you get extranodal growth, and then it becomes highly irregular. While on the other hand, if you have vascular invasion, that's rather smooth. So then we came to the 7th edition of TNM, and maybe they were quite a bit fed up with our discussions and our critical reviews because they decided not to come up with a new definition, but to leave the definition to the discretion of the pathologist, which is a bad thing if you want to have a global system which standardized cancer care. They also introduced N1C, which is specifically made for tumor deposits, but it could only be used in the absence of positive lymph nodes. And I will come back to that. Because what is confusing and potentially harmful for patients and was not understood by the people who actually treat these patients, it is that due to the changes in definition of tumor deposits, we changed the stage in which these patients were located, and therefore we changed their treatments. Because if you were in stage 2 under TNM5, like in the second part of this diagram, and you were under TNM6 or 7, you were stage 3, then you would be eligible for chemotherapy. And on the other hand, you could also cause downstaging for certain patients. So it was a very confusing time. We did some studies in which we compared also the different staging system like TNM4, 5, 6, and 7. TNM4 where we completely ignored the tumor deposits, and 5 and 6 where we had the definition, and 7 it was actually my interpretation, which is not, well, was actually based on TNM5. So what you see here are two populations, the Dalarna, which is a Swedish population cohort, and the classic trial, which is the British trial. And what you see is actually that the TNM5 had the most prognostic power, which is indicated by the AIC number, which is the lowest, particularly in the population-based. But also what's important, if we want to standardize something as important as TNM, we also have to take into account the observer agreements. And this is a depiction of observer agreements, where if you have 100% agreements, your your circle is beige, and if you have 0%, it's all red. And what you can immediately see is that if you used TNM6, then the agreement was actually very low. And if you use a ruler, then of course, as expected, it was very high. But if something is left to the discretion of the pathologist, well, you don't have a clue on where you're looking at. So there was a lot of discussion, and actually there was a lot of good journals which picked up on this discussion, which was very fortunate, I think. That brought us to the eighth edition of TNM, and we were actually kind of disappointed because nothing changed there. N1C remained, and it was still left to the discretion of the pathologist whether something would be a tumor deposit or a lymph node. We did another meta-analysis and systematic review in which we also incorporated the Japanese data. And what you could see from these data very clearly was that tumor deposits are associated with poor other biomarkers like lymph node metastasis. So the more tumor deposits you have, and the more likely it is also that you have lymph node metastasis. So that makes the N1C category kind of useless. Also, tumor deposits are associated with extramural vascular invasion, as expected. But interestingly, tumor deposits in themselves have a really powerful prognostic value. If you look at this figure where we specifically looked for liver metastasis, lung metastasis, and peritoneal metastasis separately, you could see that in almost all categories, if you combined tumor deposits with, if you looked at tumor deposits without lymph nodes, you have a high risk of liver metastasis, which is higher than when you have lymph nodes without tumor deposits. But in particularly, the combination of nodal disease and tumor deposits is very powerful and associated with a bad prognosis for all types of metastasis. And that's why the N1C category is so bad, because it only acknowledged the presence of tumor deposits in the absence of lymph node metastasis. Well, if they are there in the presence of lymph node metastasis, the outcome for the patients is actually worse. So now here we are in 2025. And actually, it has blown up. There are so many papers on tumor deposits. Many of them are actually based on the large American databases. So there are numerous papers with SEER database, but there are also very useful population data, and also more molecular information is available about tumor deposits. So let's go through that. In 2021, we decided to get together with all pathologists who actually published on tumor deposits at that time. And we performed a Delphi consensus study just to identify the issues that were still open for tumor deposits and should be urgently solved. And if you look at this Delphi consensus study, we specifically focused on the origin of tumor deposits because that has been a bone of contention with the TNM staging committee. We also, of course, wonders about the right classification in the TNM staging, and we also focused on the clinical applications of tumor deposits and how important that would be. So if we start with definitions, then it was clear that there should be a more specific definition in TNM, because the current definition has poor reproducibility and there is a poor inter-observer variation. We were also clear about that the shape in itself should not determine TNM inclusion, and also the size. So one of the things we did was we looked into this inter-observer variation in more detail and looked at which features actually are important for pathologists to determine whether something is actually a tumor deposit. So the shape. We also looked specifically for a perineural invasion, and also into things that might be associated with lymph nodes. So lymphoid follicles, a capsule, and also with vessels, like vessel walls or lone arterioles, encasing vessels, and the sinus is for the lymph nodes again. Well, the first classification of nodules with this group of pathologists, where we looked at 50 different nodules, we didn't have agreement on many things. We did agree on some lymph node metastasis and some extramurovascular invasion, but most of the nodules actually had a mixed classification. There was not 100% agreement, which was to be expected. Then we looked at tumor deposits, lymph node metastasis, and extramurovascular invasion, and we scored them for specific for lymph node characteristics and also for characteristics of venous invasion. And if you look at these pictures, you see that the lymph nodes, which are lymph node metastases, which are depicted in green, indeed have most of the lymph node characteristics. But on the other hand, things that we counted as tumor deposits also did have them. And even in some extramurovascular invasion cases, we saw some lymphoid follicles. The same is actually true if you look at venous invasion. So you have, of course, for extramurovenous invasion, you have all the vascular characteristics, but you also find them in something which we agreed on, that were tumor deposits. So if we then summarize our findings in those that were by the majority of the people classified as tumor deposits, you see that they have things like perineural invasion. They have characteristics of venous invasion, and they also do have some lymph node characteristics. And most of the tumor deposits actually have more than one of those. They have a combination of characteristics which are presence of venous invasion of vessels and also of nerves. So the origin, because people keep on thinking about the origin of things. I mean, it's the ultimate road to discovery. You have to discover the origin of the node, but you also have to discover the origin of the tumor deposits. And it might be important from a scientific viewpoint. But we don't have any evidence that the prognosis are actually related to the origin of the tumor deposit. And you cannot really compare simple extramurovascular invasion to the outgrowth which causes a tumor deposit. At least that's what we believed at the time of the Delphi research project. So actually tumor deposits are different, might be different entities, but we don't know. So we actually want to know something about the origin. Because if you look at a tumor deposit like this, you can see lymphoid follicles, you can see big vessels, and in this tiny square, you see very clearly a nerve. So everything is in there. And that's also already known from earlier research from the group of Bruno Makel from Germany. They looked at it. They looked at size in combination with those so-called origins, but also in the seminal Goldstein paper from 2000. And the majority of their tumor deposits did have actually more than one potential origin. But it's rather hard for us pathologists to discover the origin of the tumor deposit, because what we're looking at is a snapshot in time. So we did some exercises in the neoadjuvant setting because we thought, well, maybe you destroy some tumor deposits, and we showed that tumor deposits can occur based on a systematic review in the neoadjuvant setting due to fragmentation, but that's not really what we wanted to know. We're currently performing imaging studies to see what's happening during in the neoadjuvant setting, but that's also not giving us real clues towards the origin of tumor deposits. So should we actually look at the origin? And this is a picture by Paul Gauguin, and it says, where do we come from? Where are we? Where are we going? And actually, I think for the clinical implications of tumor deposits, it's maybe not so important as where we come from, but more important where we are going to. So we believe that we can explain the poor outcome which is associated with tumor deposits by the presence of the different histological highways that are present in the tumor deposits, the nerves, the vessels, the lymphatics, the diversity of highways that tumor deposits have access to might explain the poor outcome associated with tumor deposits. And also, maybe, and if you look at tumor deposits, then you see that there are no histological boundaries anymore. The tumors have come out of the vessels, come out from the nerves, and grown out into the fat. And they don't have a histological boundary as they would have when they would have been lymph nodes. So we decided to go from origin to access points. Where can the tumor cells go? Do they have access to these the histological highways which are around them? And we did a large study in 280 tumor deposits from 127 patients from our own institution. And we looked very carefully, also using additional stains to see which kind of highways these tumor deposits had actually access to. And the first figure is per tumor deposits, where you can see that most of them actually have access to multiple highways as expressed by the overlap in the circles. While on the other hand, there were still 60 tumor deposits which did not have any origin or access points to show. And per patient, the overlap was even bigger. So you have to realize that if you do this kind of study, you start, in our case, with 650 patients, then not all of them did have tumor deposits. So we ended up with 126. And since in patients, most patients did have more than one tumor deposit, it complicated this whole analysis. Because we initially thought that we could actually look at individual origins or access points to see whether that made a difference in prognosis. But if you want to do that, you need tens of thousands of patients to have any meaningful statistics. If you look at patients who have only perineural invasion in their tumor deposits, you see it's only 4 from this cohort. So if you want to have something meaningful data from like 100 patients, you have to go for thousands and thousands of patients to identify these patients. So that was not really doable. But we looked at different aspects of the number of access points. And of course, the bigger the tumors are, the more access points the tumor deposits are, the more access points they have, which could be expected. But also, we could look at the number of access points and prognosis. And what you actually see is that if you have only one access point in your tumor deposits in blue, that your prognosis is significantly better than when you have 2 or more. So diversity pays off for tumors and tumor deposits. So the poor outcome of tumor deposits might be explained because of the access of multiple anatomic highways, as we stipulated in our hypothesis paper. But also, like I said, there are no histological boundaries. So we thought, well, maybe we can do something with that. And one of the things you can do currently is look at complexity of shapes. We always could do that, but with digital pathology and AI, it has become way easier to do that. So we looked at the contour, actually. We were back at the contour rule, but not completely. So we looked at the complexity of shapes. And if you have a lymph node, it's not a complex shape. It's actually quite roundish. And the tumor is still inside the capsule. While on the other hand, if you have a tumor deposit, It's very irregular and it has no boundaries. So if you look at these pictures with computational pathology, you can determine the complexity ratio. And if the complexity ratio is close to 1, it's a perfect round structure. And if it's higher, then it's more complex. So if you compare lymph nodes with extraneural extension of lymph nodes and tumor deposits, you see an increasing complexity ratio. And also this complexity ratio is associated with prognosis. If you have a low complexity ratio, so a smooth contour or a lymph node metastasis, you have a relatively good prognosis. If you have a high complexity, which is present in tumor deposits, you see that your prognosis is worse. And if you want to compare that with the literature, it's kind of difficult because you actually want to see whether extranodal extension, which is also irregular, is better or worse than tumor deposits. You cannot really do that because there are no studies available. But what you can do is network meta-analysis. Actually, it's a mixed effect hazard ratio from a frequentist network meta-analysis, which is very complex statistics. But that means that you can compare different studies that looked at different features and make an indirect comparison. So you look at extranodal extension versus tumor deposits, and it's not present in a single study, but by combining all these studies, you create a network in which you still can compare. And what you see from this study is that for disease-free survival, specific survival, and overall survival, tumor deposits in combination with lymph node metastasis are actually associated with a worse prognosis than extranodal extension from lymph node metastasis, which are in part worse than a lymph node metastasis. So tumor deposits are bad. They are kind of outer space, as we call it. They have access to multiple anatomic highways. But the question is, are they progressing from lymph nodes or not? So then we really went back a little bit to the origin because it remains very intriguing. And we did that using 2 relatively new techniques, at least on paraffin-embedded tissue. One is proteomics, and the other is spatial transcriptomics. And we make tissue microarrays from patients that did have both lymph node metastasis and tumor deposits, as well as other features, and we compared those. And what you see in both transcriptomics as well as proteomics, that the tumor deposits have different proteins, different pathways, signaling pathways which are involved. So in tumor deposits, we see more things associated with matrix remodeling, metastasis, invasion, motility, while in lymph nodes, it's more to do with immune status, which is, of course, to be expected. Which was very nice is that we saw some specific proteins which were differentially expressed both in spatial profiling as well as in the proteomics experiments, like SFRP2, which is expressed by cancer-associated fibroblasts and is associated with migration and invasion of cancer cells. We could also confirm their presence in the tumor deposits and their absence in the lymph node metastasis with immunohistochemistry, and also MXRA5, which is associated with matrix remodeling. And if you look at these proteins in large other series, they are, of course, associated with a poor prognosis in colorectal cancer. So that was actually very nice. We also worked together with a group of Victor Koelsner in Switzerland to see whether the CMS score was different for a lymph node metastasis and tumor deposits. And as you can see from these pictures, a CMS 4 is the bad one. If you look at CMS scores, and that's in green. And what you see in the tumor deposits is that they are largely green. Lymph node metastases are more bluish, And that was a very clear difference. So also, we've now shown that molecularly, the epithelial, the tumor cells that are present in the tumor deposits are actually worse than those that are present in the lymph node metastasis. It's also reflected by more clinical studies, and this was a recent study which we did with some surgeons, where we looked at the mode of circumferential resection involvement, where you can see actually that it's bad when the circumferential resection margin is involved by the tumor, but also by tumor deposits or multiple factors, but not so much if it's involved by lymph node metastasis. And we already got that feeling for a long time, but most of the circumferential resection margin studies were too small to really say something about lymph node metastasis. But here you can see that the presence of a tumor deposit in the circumferential resection margin for overall survival as well as for disease-free survival is as bad as having the primary tumor there. So tumor deposits are bad, outer space, highways, molecular aggressive, and they are different from lymph nodes. But do they actually contribute to metastasis? So in order to look at that, we use a technique which was described by Camilla Nagtegaal, where you look at a poly-G. And poly-G areas are hypermutatable DNA areas, which can be compared to a little bit to microsatellites. And by analyzing these areas, you can make genealogic trees, evolutionary trees, if you want. So that's what we did. We looked at patients who did have tumor deposits and lymph node metastasis, and we compared them, as well as the primary tumor, to liver metastasis. And what you then get is this kind of tables and also these dendritic trees, like for the liver and also for the peritoneum. I always find them a little bit confusing, but I think this is more clear. If we looked at the origin of liver metastasis, then we could say that 23% of them was actually directly related to tumor deposits in red. The same percentage was associated with the lymph node metastasis, and 1/4 was directly associated with the primary tumor. And in gray, we have the mixed group, where most of them are also associated with tumor deposits, but also with the primary tumor, where we couldn't really distinguish the origin. So this is for liver metastasis, but for peritoneal metastasis, this was different. For peritoneal metastasis, lymph node metastasis are not important, but tumor deposits are. So it's good to know. And currently we're looking at lung metastasis. So then I would like to move on to the TNM classification. In the Delphi study, we all agreed that N1C is not a good reflection of the prognosis which is associated with tumor deposits. And shape nor size should determine inclusion in TNM. And what's clear is that tumor deposits are worse than lymph node metastasis. So there are a lot of studies now speculating in what's going to happen in the next TNM classification. And there are different scenarios which are possible for this approach. And I would like to focus now on scenario 4, because people are worried about the poor prognosis associated with tumor deposits. And they have considered tumor deposits as stage 4 disease in the literature, which should be a huge shift. And if you look at the papers that actually claim that this should be the case, these are these 4 papers. And if you look at the number of patients that actually do have tumor deposits in these series, it's the first number. So the first study has 100 people with tumor deposits, in total of 228 people, and the other ones are considerably smaller. except for the study from Tong, which is bigger, but then still only 200 patients are there with tumor deposits. So these studies actually say, well, tumor deposits are so bad, they should be stage 4 disease. Well, we thought, well, that's a bit short. You shouldn't say it so clearly. So what we did is we used the SEER data, which I do not always like because there is a lot of heterogeneity in the data. And there's no proper histological review, which is the problem with most of the cancer registries, of course. But I thought for this purpose, it would be actually interesting. So what we did here, we selected all stage 3 and all stage 4 patients in the SEER database. So you have huge numbers, which you can see in the first column below. And we split the stage 3 as well as the stage 4s into those that do have tumor deposits and those that don't. So you see for stage 3, you have 3 lines. The yellowish one, which is stage 3 without tumor deposits. I think orange is all stage 3. And the green one is stage 3 with tumor deposits. So there again, it's clear tumor deposits are bad. They are worse than lymph node metastasis. So that was comforting that we found it again. But if you look at stage 4, you can do the same. So stage 4 without tumor deposits in blue, all stage 4 in, turquoise, and stage 4 with tumor deposits in pink. And again, you see that the presence of tumor deposits is associated with a poor outcome. But since there is a major division between stage 3 cases with tumor deposits and stage 4 cases, I don't think that tumor deposits should be placed in the M category of TNM. So that's about TNM staging. I would like to go back a little bit towards the definition development, because the definition of tumor deposits is actually the basis of everything. We first have to agree on the definition developments. And in 2021, we started working on the new HSCC TNM classification. So I thought this would be a good approach. So we already have seen the various independent studies where we did systematic reviews and meta-analysis. We evaluated the available data and we performed the Delphi consensus procedure already. So we came up with a group of pathologists to the initial definition. We sent it out to experts and stakeholders and we adjusted the definition, and we kind of hoped that it would be in the 9th edition. Well, there was a severe delay of the 9th edition, and so the definition is not really out there, and the 9th edition of TNM for colorectal cancer is also not out there yet. But this is actually what we came up with. So we think that tumor deposits represent discrete tumor nodules of any shape, contour, or size in the perirectal and pericolonic fat, away from the leading edge of the tumor within the lymph nodes, a lymph draining area of the primary carcinoma. It can originate from different histological structures, including lymph nodes, vessels, and nerves, and therefore may contain foci of extramural venous invasion and perineural invasion. The feature distinguishing a tumor deposits from EMVI and PNI is the presence of unequivocal tumor extension from the vessel or nerve into the surrounding fat or the fibroconnective tissue. I think this is a useful definition which incorporates the things we have researched over the years and also the Delphi consensus. Then we come up to the clinical usefulness or the clinical impact of tumor deposits. And one of the things which we had discussion about, especially in the beginning, is that if tumor deposits are not lymph nodes, are these patients then, should they be treated or not? That was in the time then when people actually thought that lymph nodes were more important than tumor deposits. So that's a different time. But now, if we look at treatment of patients, you could wonder whether patients with tumor deposits should actually be treated the same as patients with a normal stage 3 given the fact that they have a poor prognosis. Well, there are not many studies available. There are some cohort studies from China, and also there is a post-hoc analysis from a phase 3 study in which they looked at different treatment regimens, but not treatment versus no treatment. So we did a study using this SEER data on the one hand, and also the Dutch cohort data on the other hand, where we compared stage 3 patients with lymph node metastasis with tumor deposits or with a combination of both. And here you can see the overall outcomes, but what's more important is the effect of chemotherapy. What you of course have in population-based research into chemotherapy is that there is a severe bias, which means that the effect of chemotherapy seems very beneficial, but that's because if we have those people that are not fit enough to get chemotherapy, they have of course a survival disadvantage. But when you compare 3 different groups, then you can compare the relative effect of chemotherapy, which you can do with these hazard ratios. And what you see is that for each and every group, so the lymph node metastasis, the tumor deposits, the lymph node in combination with the tumor deposits, for the Dutch cohort and for the SEER cohort, actually the hazard ratios are the same. So that means that there is an equal effect of chemotherapy for all these patients. So patients with tumor deposits with or without lymph node metastasis should be actually treated the same as based on these data. We're currently looking forward to the outcomes of the COMET trial, and the COMET trial is an imaging trial where we can really look in whether we can recognize tumor deposits on MRI and also on CT, which also will help us bring this research forward, because then we can actually follow them in time. This was, for now, the tumor deposits, a story which was sponsored partly by the Dutch Cancer Society. And these are the people who actually worked a lot with me, with Phil Kirk, Gina Brown, Nelleke Brouwer, Amy Lord, Christina Graham-Martinez, Isa Erdogan, and Yao Xu. And the story will continue at Ghent Pathology, but then I will be talking about the lymph node story. This was the tumor deposit story, and I hoped you like it. Thank you for listening.
Thank you very much. That was fantastic. It's really great, Iris, and just shows how tumours continue to outwit us. They want to survive, and so travel along different highways, perhaps like we would, using, I don't know, Google Maps, to find different alleyways to avoid blocks in the traffic or whatever. So they're, yes, as I say, sort of constantly outwitting us, and we shouldn't underestimate their abilities to evolve and improvise. So I've seen that there are questions already. So I'm going to start at the top with Neil Shepherd. He says, hello, Iris, great talk. Can we expect that anything good will come out of the TNM9 for colorectal cancer?
Yeah, well, that's a difficult question, because we are busy with TNM9, and I have seen some good work, but there's kind of an embargo about it, so I cannot really say. But I'm not unhappy. Let's say that.
Okay, that's great. So Nick West has 2 questions. We'll start with his first one. He says, in the study assessing the impact of the various mechanisms of spread at the CRM, where lymph nodes mets at the margin are less important than TDs, do lymph node mets with extra capsular spread at the margin behave more like TDs in terms of their recurrence risk?
I presume they will. But the problem with this study was that it was a national database study where we use in the Netherlands the standardized reporting, where you can indicate why the margin is positive. And so that made us distinguish between the different forms of involvement, but we didn't do a review of the histology, so I cannot really say. But I expect that, given the fact that extranodal extension from a lymph node is different and associated with a worse prognosis than a simple lymph node metastasis, this would also reflect in the slightly increased risk with regards to circumferential margin involvement.
Okay, that's great. Thank you. Perhaps we'll go to the second question of Nick, and that's if tumor deposits are an independent risk factor to traditional TNM, why should they be included in the TNM stage when other well-known risk factors are not? So, for example, perineural invasion, tumor budding, tumor stroma ratio, MMR status, etc. Is it not cleaner to remove them from staging entirely and consider them along with all of the other risk factors we use for everyday treatment decisions? Or do we need to, number of questions here, or do we need to include all of the other factors in staging as well?
Well, I think compared to the other factors, the impact of tumor deposit is bigger. The other thing is that I can understand where your question comes from, but the problem is that tumor deposits have been incorporated in TNM for a long time now. And I think we cannot go back to kind of ignoring them. I agree with you that there are many factors that are have prognostic value and are not in TNM, but the problem with these factors is that they are currently mostly ignored. Although you can say, well, this is a high risk feature, but in clinical practice, at least in our country, and I think in many countries over the world, we as pathologists, we acknowledge these factors, we report these factors, but the clinicians, they don't really use them. And I think the impact of tumor deposits is so huge that they shouldn't be ignored. So I think they should be in TNM. You cannot remove them now.
Yeah. So can I? Okay, sorry, I'll go back to the question from the anonymous attendee. To what extent do you think tumor deposits have a risk to be misclassified macroscopically? And particularly in the case of T3 disease that spreads quite far away from the colonic wall in an irregular manner.
So what you mean is that it's that's just invasion and not a tumor deposit. Well, we have been looking for to define actually a distance from the invading edge to the tumor deposits, and the Japanese are doing some work in there. I think at one point in time there was a 3 millimeter rule which we use for everything. So we also used it for the distance from the invading edge of the tumor. But I think, and also the people in the Delphi consensus, we couldn't really agree on a distance. And for practical reasons, we said, well, if you would macroscopically identify something as a lymph node or a nodule, which is, I think, the more correct words to use here, then you should consider it a tumor deposit macroscopically if it's a tumor deposit. It might be that if you have a very irregular tumor growing, that you might miscalculate it. I cannot exclude that, but I'm not sure whether that's really very frequent, and also whether that's really a bad thing.
Okay, so I'm just going to ask my question, and then I'll continue on with the others. I'm also involved in the TNM staging system for ophthalmic tumors, and I realize by working on those various chapters that we are very restricted in that the TNM staging is predominantly anatomically based.
Yeah.
And it doesn't take into account clinical prognostic parameters or genetic prognostic parameters. And I guess that's sort of what Nick West is sort of indicating. So, I mean, should we be moving should we be modernizing the TNM staging system to almost have multi-parametric design multi-parametric algorithms which incorporate clinical, histopathological, and genetic prognostic factors, which would perhaps be more precise in prognostication than a purely anatomical one?
Yes, well, yes and no. On the one hand, you're correct. TNM is just anatomical snapshot of the tumor in time. But the problem with global systems, first of all, is that you cannot really incorporate things like genetics, etc., to a great extent, because then a big part of the world, they cannot be used. So in a way, that would, yeah, that's also why TNM keeps, and also like the WHO, we have different levels of evidence and different levels of refining staging and classification, because it should be, you should be able to apply it like everywhere in the world, in every setting. The other thing is that if the more things you incorporate, the more different categories you will end up with. And while we all, on the one hand, strive to personalized medicine, clinical practice isn't really like that, because then you end up with maybe 20, 30 different categories, but everything between 21 and 30 will be category 5, so on the one hand you split everything, and then in the end you will lump it together for treatment decisions. And of course we know that there are specific treatments for specific targets, but I think that's something else. And the more different categories you will make, the harder it is to really obtain the evidence you would need. So if what I mean is that you can have a specific target if the tumor has something specific, but if we're looking at prognostic biomarkers, you can prognostic, you make a very complex scheme and make every patient his own, but then it won't work. We won't get any really studies where you can say, well, approximately this is 70% and this is 50%, but because you have so many different groups, it really doesn't say anything anymore. Yeah.
I understand what you're saying.
Yeah.
Okay, we'll go back to the questions in the question box. So James Morris asks, is there any information on the microbiota of tumor deposits?
No, not yet. But we don't know. I mean, we do know that there is a microbiome that can also travel with metastasis, for example, towards the liver. So it would be very interesting to see that. The problem with things like microbiome, and that will be solved in the coming years, is that you actually want like fresh tissue, because you have this special workup for microbiome, which is optimal for these analyses. But the point is that with tumor deposits, you usually diagnose them after your whole macroscopic and microscopic workup. So you diagnose them under the microscope, and then it's too late to have your microbiome. But I think it would be very interesting, and we have more opportunities to do it on normal paraffin embedded tissue. So that, yeah, cool idea.
Okay. Mark Aarons says, great talk, thank you very much. Transcriptomic analysis found more CMS4 in TD, but more CMS2 in lymph node metastases. Is this indicating more important interactions between tumor cells and the tumor microenvironment in tumor deposits?
Yeah, I think so. I definitely think so. And you also can already see that if you look at the microenvironment of tumor deposits, where you see more activated fibroblasts, for example, than you do in lymph nodes. And we know that the interaction with cancer-associated fibroblasts is really important in invasion and aggressiveness.
Mm-hmm. Okay, thank you. Maurice Loffrey says, fabulous talk, many thanks. Does your proposed new definition of tumour deposits miss a comment on distinction of tumour deposits from nodal disease with extranodal tumour extension? I'll continue reading. I'm concerned that this may be the new grey zone limiting reproducibility of assessment. That is, how much extranodal tumour extension is required to make it a tumour deposit?
Yeah, that's a good question. I have to think back at the exact definition, and you might be right, Maurice. I will go. I will have another look. Thank you.
Okay. And then Kaushik Dasgupta asks, does this mean in N1C we do not need to do elastic von Giesen or elastic H&E from tumour deposits, and PNI is also not an exclusion?
Exactly, correct. So we don't need to go into detail about the structures that are there. If you believe, I mean, if we're talking about extramural vascular invasion and you see the vessel and there's tumor in there, that's extramural vascular invasion. If you have tumor deposits, which is outgrowing into the surrounding fat, then and destroying the vessel in the process, then it's more than extramural vascular invasion, it's a tumor deposit. So you don't need to do any extra stains. And in many of the tumor deposits, you find small nerves. The point is, you have the neurovascular bundles, and so the nerves and the vessels, and actually the lymphatics as well, they are in close proximity to each other. So especially if you have a larger tumor deposit, it's not strange to find some vessel or some nerves in there, and we shouldn't focus too much on that. The fact is that there is this tumor. It's a nasty one. It's growing out of something. So that's the message this tumor deposits brings, and not that it came from a vessel or lymphatic, or it also has the potency to go into the vessel and move on to the liver. So yeah, no more stains. Very sustainable.
That's great. Okay, I don't have any further questions here in the box that I can see. Just lots of praise about your talk. So I think people learned a lot from it. I guess I have perhaps a couple of concluding questions. So, you've been speaking about carcinomas, and I just sort of wonder, could this system or idea of tumor deposits be also transposed onto other tumors which arise in the gastrointestinal tract of the rectum, for example, mucosal melanomas? Do you know if a similar phenomenon occurs, and whether we should be taking tumor deposits of those into account when we're doing the staging?
There are no studies that I know of about melanomas, gastrointestinal at least, and but for neuroendocrine tumors, we know that tumor deposits can happen, and that there's also 1 or 2 studies, very limited, but I think it will be a general mechanism.
Okay, that's great. Thank you. So I think we've run out of time now, and it just gives me, the last couple of seconds to thank you very much for your excellent presentation. I certainly have learned a huge amount, and so thank you very much for your time and for the presentation. And with that, I'd just like to let everybody know that there will be another Jean Shanks Pathology Foundation and PathSoc Grand Round lecture in April. It will be April 16th. Sorry, I'm just checking that date. Yes, April 16th. We don't have a speaker as yet. However, that will be the speaker will be confirmed. We do, however, have a speaker for May, and that will be on May 14th, and that will be Professor Jamal Hanjani. So if you could all put a mark in your calendars for these 2 upcoming lectures, but we will, closer to the time, notify everybody about the speaker in April and also the speaker title in May. So with that, I thank you all very much and wish you a pleasant day. And thank you very much again, Iris. Goodbye.